Hello, everyone. Hello, CSW members and anyone who may be joining us from across the country, wherever you are, wherever you're at. Thank you for spending another hour or so with us. We are so happy to have you. My name is Alexandra Zanes. I'm the Social Policy and Communications Coordinator here at the Canadian Association of Social Workers. Welcome to our platform and welcome to our continuing education opportunities. A couple little housekeeping notes before we dive into this incredible content. I'm so excited to be joined by two amazing speakers today. But before I get into that and what we're going to be talking about today, I just wanted to let you know that our platform is completely customizable, so you can move everything around and make sure that it's the best viewing experience for you. If you would prefer the slides to be bigger, if you prefer the presenters to be bigger, whatever works best for you. There also is a question and answer box, so please feel free to type your questions throughout the entire presentation. I'm going to be online to moderate while our presenters are presenting, so please just type your questions whenever they come to you, and I'd be happy to compile that for a bit of a formal question and answer period at the end, where we can hopefully dive into a couple of those questions that our audience members may have. So use that question and answer function whenever you have something you would like to put out into the webinar universe. In terms of your continuing education certificate, you should be able to find that in the course completion tracker at the bottom there. You're also always welcome to get in touch with us if you are struggling to get that certificate to work. With all that being said and done, you're always welcome to connect with us at the CSW. There's a couple ways you can do that. You can connect with us on Twitter. You can connect with us on Facebook. If you go to the handout widget, there is a link to our peer-to-peer support group where we hopefully dive into some more of these topics, such as psychosocial practice in death dying. So please check that out if you are looking for some peer-to-peer support. Other than that, I think we should be good. Like I said, type your questions and comments as they come. I am going to pass it over to our two incredible webinar presenters. We are joined today by Marnie and Zelda, who are going to get into these key principles of psychosocial practice in death, dying, and bereavement. We are so lucky to be joined by them at the CSW. They are both social workers. And you know what? I'm done talking. Let's take it away, Marnie and Zelda. I'm so excited. Thank you for being with us today.
Well, hello, everyone. My name is Zelda, and I'm joining you today by audio only. So you won't be seeing me in an animated form, which might be good for you because I tend to move my arms around quite a bit when I talk. So thank you very much for the invitation and having Am I to continue?
Yes, you're good, Zelda. Keep going.
Okay, great. I'm just hearing sorry about that. So just again, thank you for having me today with you to present on the key principles of psychosocial practice. I'm joined with, very happy to be presenting today to you with Marnie Thompson. I'm very happy to be working with her, and I'm very privileged to have this presentation with her today. So I'll start off the presentation. Marnie will join in at midway, and then I'll pick up a little bit later, and then Marnie will finish the presentation at the end. So do we change our own slides, Alexandra, or are you changing that for us?
Sorry, I muted myself. I'm happy to change the slides for you if you want to just let me know.
But I can change them myself?
You can also change them at the bottom. There's a next button.
Okay, perfect. Thank you. Okay, so just briefly, the objectives today are just to draw your attention to what our objectives are. Well, we're going to try to define psychosocial end-of-life and palliative care, introduce some key principles in death, dying, and bereavement, look at some strategies and approaches that are congruent with this, look at some common risk factors, as well as talk a little bit about some resources that could be helpful to people facing death, dying, and bereavement. So just to briefly touch on the Canadian context in death and dying, about 90% of people die from chronic illness in Canada. That could include cancer, heart disease, organ failure, dementia, and frailty. Number of deaths, as we know, are increasing. As the population is aging, the number of deaths are also increasing. And we also know that people, even though individuals have expressed in many different surveys and so on, their willingness and wanting to die at home. Actually, there was some research that was done by the CHPCA, and they said up to 90% of people wanted to die at home. Most people continue to die in hospitals. About 60% of people continue to die in hospital. So we still have a lot of work to do in that area in terms of making that more congruent with what people's wishes are. We also know that with the increasing demographics, and there's an increased pressure on caregivers. When I talk about caregivers, I mean families and significant others. And again, when we talk about families, we mean family of choice. And we know that 80% of care that's provided at home is done by caregivers. And as well, we do know, and it's come to the forefront in the last few months for sure, that there is a significant amount of care as well that is provided by families and significant others in long-term care. So that's something that we need to keep in mind as we move forward. There are a lot of expectations now with regards to looking more closely at what we mean by person-centered care and integrated care. And we also know that there is a lack in, and there's gaps in professional training around death, dying, and bereavement. I think, though, now with webinars and e-learning, it's certainly opening up opportunities for social workers and increasing our accessibility to at least online training in this area. We know as well in the last few months there's definitely been an increased public discussion on end-of-life care and decisions. Certainly there was a discussion prior to the pandemic with regards to medical aid and dying that opened up the discussion around end-of-life, but certainly in the last little while we've had a much more of an in-depth kind of reflection on it, I would say, with regards to a lot of the tragedy that we saw happening during the pandemic. And we also had now more of an opportunity to look at how are we caring for a segment of our population, a vulnerable segment of our population, which is our seniors. Thank you for changing that slide for me. Palliative care philosophy, just very quickly, it's focused on suffering and reducing suffering and improving the quality of life. So those are two very key principles when we talk about palliative care. We also know that it is focused on individuals, the person that has the illness, but also on their families and their caregivers and their significant others. And there is as well a focus on grief and bereavement, because we know that when we are caring for someone who is dying, when we are involved in that phase of life, there is a huge impact on not only the person that is faced with the illness, but also those that are surrounding that person. And so we need to focus on grief if we're focusing on suffering, and we need to focus on bereavement as well. So it's an integration of all of these ideas, and it also talks about palliative care is not only for people that are dying in palliative care units or in palliative care residences or hospices, but it's also looking at the provision of palliative care across all care settings. When we talk a little bit about palliative care, the World Health Organization is a definition that most will refer to. They are actually in the process of updating their definition, but this is a definition that we have for now. And again, it really just goes over the key elements that sometimes people have misconceptions or ideas about palliative care that are not actually, correct. So it's, again, just quickly to go over, it's a relief of pain and other distressing symptoms. So it's not just focused on pain management, although a lot of people think palliative care is equivalent to symptom management, but really it's looking at all symptoms, distressing symptoms. So that includes psychological, social, spiritual aspects of care and also of distress. It uses a team approach. So what it entails to do is to bring in the expertise of a number of different professionals and others that can add to this whole notion of whole person care, of holistic care, of caring for the whole person. It looks at primarily as well at the quality of life, and it's not the quality of life and the way that we may define it for ourselves, but it's really on the quality of life as defined by the person with the illness as well as their family and significant others and their caregivers. So what does life and quality of life mean to them? Quality of life to me might mean for me to die in my own bed at home with my cat next to me, but a quality of life for someone else might mean that they would prefer to die in a hospice and be surrounded by the staff that's there and also with their family. That might bring them more comfort. And also now we talk a lot about palliative care as being introduced much earlier on. So one of the major misconceptions about palliative care is that it's only when someone is actively dying or in the last few weeks of life. But in fact, palliative care's focus is on living until you die and not on necessarily on the dying last few weeks. That's end of life care. But it's really focused on all of the living that must go on and continue to go on until the person is no longer there with us. So when we think about social work in palliative care, we talk about being of support to the person, their families, and caregivers throughout the illness trajectory. We talk about accompanying families and caregivers in their grief and bereavement. So it's not only during the living part, but it's also after the person has died. And how individuals and families live their illness. The medical profession, for example, is focused on how they can manage that illness. Our profession is focused on how people live that illness. So how does that illness impact their life? How does it impact their family, their relationships, the way that they're functioning, their ability to adapt? All of those things are extremely important to us in our work that we do with death and dying. One of the key words that comes to mind for me is transitions. And so when a person is when they're pronounced that they have a life-threatening illness, the moment that they start with transitions is right there and then. So we're really looking at how they're transitioning through their living process until death. And so it's really how the illness impacts the individual, their functioning, but also how it impacts their family and all of the systems around them, and the gaps in that could be created by this introduction of an illness into a family life. And some of the things that we look at is what we call holding the tensions. There are not a number of tensions that exist when illness is in a family life, as I would say. Not everyone in that family system is living the same experience of that illness, of course. The person who's living with the illness is having a very different experience than perhaps their spouse, their partner, their child, their relatives, etc. And so there are a number of tensions that exist in those systems. And those are the areas that social work and our competencies can be we can bring a lot to the table in terms of our skills, in terms of helping people negotiate, helping people communicate, helping people live with those conflicts and those tensions. And at the same time, they're also living with the distress and suffering. So all of those different elements come into play. So when we look at hope and despair and denial and acceptance, those are different tensions that are going on. We know that, for instance, there could be a number of family members. I'm thinking of one particular instance where I had a 62-year-old woman with advanced lung cancer, for example. She was in a point where she was completely acceptant of what was going on. She wanted to have as much information as she possibly could about her illness. She wanted to be on top of it. She wanted to make decisions. She wanted to be autonomous in that. And yet you had her partner who was in despair and in an inability to accept and be aware at the same level as the person that was living that illness, that woman. And so there was a lot of miscommunication between the two of them. There was a lot of ambiguity. There was a lot of non-saids, as we said, non-communication. And that caused a lot of conflict, and it caused a lot of tension, and it caused a lot of suffering between them because they were not able to really share that experience in the way that they would want to. And we were able to help them to communicate better, to look at how people live different ways, but yet can still find ways, commonalities in the way that they're living the illness. So it's very important to look at the different ways that people are living an illness and the tensions that they're holding in order to help them live the best that they can together with the illness that's in their lives. So I'm going to pass it on to Marnie now, who's going to talk about grief. So go ahead, Marnie. Thank you.
Thanks, Zelda. So all of you might be wondering, we've got about 8 slides here on grief, and as Zelda said in the introduction, grief is really fundamental to psychosocial work in palliative care and at end of life. So we're taking the time here to give you some basic information about grief. So I think it's important when we look at grief and when we see people grieving to understand that it's a natural and normal reaction, that it's actually part of what helps people to adjust to life after loss, and that it very normally and naturally includes soon after a death preoccupation with thinking about the person who died and how the death went and those kinds of thoughts. That kind of intensity about missing and longing for the person is very normal after a death. And that there would be intense and persistent emotion, again, normal and natural response to loss. And very often for newly bereaved people, a kind of contraction or pulling away from their usual activities of life and social supports and connections. There tends to be a kind of slowing down and drawing in soon after loss. I thought I had an ability to move along with my cursor, but I don't, so I just have to open something up. So illness and grief, as Zelda said in her introduction, impact us in all ways. So thoughts, feelings, physically in our bodies, in our behaviors and choices, in our social relationships, and also in how we make sense of the world, how we find purpose and meaning, and how our values come to play in our illness and grief experience. I have a special interest in complicated grief, and I'm also often asked about it, so I'm just putting a little bit out here around complicated grief. I call it complicated grief. I was trained in complicated grief, but for those of you who might be searching and newly learning about this, it's also called prolonged grief disorder. It's been proposed in the DSM as persistent complex bereavement disorder. It looks like the next ICD version will call it prolonged grief. I think that's what we're going to settle on eventually, but it has a number of names. But I think it's important to know it's an intense and long-lasting form of grief that takes over a person's life. And I think that takes over element is really important when we're wondering about whether someone's suffering from complicated grief. I personally practice and believe 30 years into palliative care that grief is forever. It's not something we get over when somebody who matters to us dies. It's not like we kind of have closure and then we don't feel sad or feel the loss anymore. I think grief is a lifelong process, but that intensity and disruption that we experience early after a big loss usually is not persistent. You know, it begins to kind of retreat into the background and no longer is all encompassing. Whereas for people with complicated grief, we're seeing that kind of intense degree of disruption and despair persisting over long periods of time. Some risk factors for complicated grief, and this comes from, I don't know if any of you are aware, there's a fellow from back east, Eugene Dufour, who in partnership with the CHPCA and also Hospice Palliative Care Ontario has been doing a fabulous series on complicated grief for them. And this is one of his slides, which he has very generously allowed all of us to share. So some risk factors: intense initial grief reaction, alcohol and drug misuse, a history of mood disorders or anxiety disorders, and I would say a history of any mental illness is probably a premorbid condition for complicated grief. A context of multiple other losses as a person approaches this next loss. an insecure attachment style or excessive dependency on the person who died, that it was a long relationship, and in particular, a long caregiving relationship, and a person who has negative beliefs about themselves, negative thoughts about who they are and the choices they're making and their activities and actions. So those are the kinds of things that as you're watching someone anticipate a death or face a death or is newly bereaved, that you would be wondering about as risk factors for someone who may develop complicated grief. We've been doing lots of webinars around COVID-19 and grief, and this is from the Hospice Foundation of America, who also put out some fantastic learning opportunities. So these are some points that Ken Doka came up with around COVID-19. And as we look at, I think, complicating factors for bereaved people, that the COVID-19 deaths are often relatively sudden and unexpected. We're losing people who were previously well and able, and the experience of the illness for them is sudden and rapid death. That in the context of someone having COVID-19 who may be approaching end of life, very often in-person visits are restricted, so family members aren't able to connect and be there to love and support in person their person who is dying from COVID-19. The contagious nature of the disease, which has got us all kind of afraid and distancing and not quite sure how to handle connection and support in the context of the virus, and also survivor guilt, feelings about how come that person and not me, particularly if it's someone that we're up close to and that we love and have been in contact with. Real distress and despair around how come this person experienced the illness in this way and got sick and died and I didn't. Changes to what we're able to do in terms of memorials and funerals. Very often they're happening virtually or online, and many family members are choosing to postpone them, thinking at some point in the future we will do the funeral when we can all come together. But what happens is it really cuts people off from their support systems, and that immediate kind of social response after a death happens. Anger at the world and at God, and why is this happening? And often very intense anger. A sense of stigma for having having COVID-19, and how that may be difficult to say out loud to your supports and your community when you're seeking care and attention after a loss. The non-death losses for many people, the kinds of things that we would normally do for supports, whether that was going for a walk with a friend, seeing a counselor, having massage, that certainly in the early time of the COVID pandemic, we lost access to those kinds of things, so people not able to access their usual supports. The disenfranchisement of non-COVID deaths, that there are still people dying of cancer and heart disease and car accidents and those kinds of things, but there's been so much attention in the last while to the numbers of people dying of COVID that sometimes I think for people it has felt like those deaths are not as significant or not as meaningful. And then the last one, as Eugene was saying in the last slide, I think a real increased risk for complicated grief because of the sudden and unexpectedness of it, because of the sense of wrongness about it, because of the isolation that people are feeling. I think we have to be mindful that there may be more incidents of complicated grief post-COVID-19. So this comes from Bob Niemeyer's work and a presentation that he did many years ago in Oregon. And I think it's a really useful tool to just have for all of us as practitioners when we're wondering about how people are doing in their grief. So a symptom snapshot, simply ask a person, if I'd seen or heard you talk about your loss 3 months ago, what would it have been like? What would I have been hearing or seeing? To investigate, what I call investigate integration. So tell me about the person that you lost, tell me about the death. And what you're wondering there when you're listening is this person able to share with you a kind of coherent and cohesive story about the loss, or is it so difficult to speak about that they really can't put the pieces together and tell it to you? And what's important about that is you want to know that a bereaved person is able to acknowledge and name the loss, and in particular have the skills to share it with their supports, to share it with their community. And if that integration story is not there and not well practiced, that's an area for concern. And the last one, credulous questioning. When Bob Niemeyer presented this, he said, if you want to know how someone's doing in their grief, why don't you just ask them? So to say to somebody, how are you doing? Because I think a person's own self-evaluation or sense of how it's going is really key critical information. And again, brings that psychosocial social work lens where we really come from and start from a person-centered place. So it might look like this person's in 10 out of 10 distress to me and I'm really worried about it, but what's their own evaluation of that? Is it actually a 4 out of 10 because they know themselves to be very emotional and expressive, and this is really quite normal? So again, a really simple tool, snapshot for you to have as you're looking at people in their grief. And then some basic tips. And I don't, when I'm talking about grief, I'm not just thinking after someone dies. I'm thinking about working with patients as they're facing their end of life and their significant illness, and their family members and caregivers, and also into bereavement. So basics, start the conversation. You know, don't be afraid to ask the person who's dying or their family members, you know, what was important about this person's life? What did you love most? What has been most meaningful? What are the highs and lows of your life as you look back? And the same as you're talking about someone who may have died. And I think really important with bereaved people to give them the opportunity to revisit the illness and dying process. Often there are so many changes that feel out of their control and out of their hands along the way that I think it's very important after the death to give family members who especially were involved as caregivers a chance to kind of process and think about that. And also very often for patients, as we come into contact with them, they've had many encounters with healthcare and doctors along the way. How has that gone? You know, where are places that have felt you know, empowering and strengthening, and where are places where you felt really vulnerable and challenged? And then to listen wholly to the story that is shared with patience and attention and presence, to not kind of skip ahead for what our assessment questions are or what we really want to know, but to kind of get grounded and be open to whatever the story is to be told. And I'm jumping into the next one there, that there's a wide range of normal, that it's really not useful for us to judge, prescribe, or fix, especially as we're building relationship and rapport with someone. We really want to hear any and all that there is and that feels important to be said. And then to talk about resources. And I think not just the resources out there, like handing pieces of paper to refer people to other things, but helping the person to remember and rediscover what their own resources are, where their sources of strength are. What gives them a sense of power and capacity. So working with that with people. I'm not going to talk about this slide too much, but in case people are curious about how to assess for complicated grief, these are some very good tools. The first one is the Brief Grief Inventory, and it was used by Project Liberty in the US post 9/11 as part of a really quick survey of people after the attacks on the towers, to really assess for complicated grief challenges. The next one is the Inventory of Complicated Grief, developed by Holly Prigerson and her associates. And then the last one is a reference for the criteria that was proposed for the latest DSM. My last slide here is to just introduce what Zelda and I came up with as the kind of 5 key principles that we wanted to highlight with all of you today. That the psychosocial perspective in palliative care is really person-centered, that we start with where and who the person is and where they're at, and we look at them holistically, not with that medical lens, not with the practical nursing lens, but in all of those areas, socially, spiritually, physically, emotionally, how is and who is this person? And we bring that to their care, we bring that to the interdisciplinary team, and we bring that to the setting of goals of care. Identity, so not just who the person is in terms of their work and career and demographics, but also their cultural orientation, their sexual orientation. What are the things that have brought meaning and purpose to this person's life? That we come from a strengths-based perspective rather than a deficit place. You know, we don't come from what's wrong with you, but really who are you and what are your strengths, and really helping people to remember those and bringing those to decision-making and care. An interdisciplinary approach, as Zelda mentioned early on, as part of the World Health definition of palliative care, and that we see family and friends as central in the unit of care. So it's not just patient-focused. It includes those caregivers and support people around the person with the illness. I'll pass it to you, Zelda, for the next few slides.
So we basically covered already a bit about holistic and person-centered care, but just to give you a little bit of a sense of what are the key dimensions, and these are very, very much in line with social work values. So you'll see that palliative care principles and approach are very much in line with social work values. Respect, emotional support, physical comfort, information and communication are key. Continuity, helping people in transitions, care coordination, advocacy involving families and carers, and of course access to care. So those are really the key principles and when we talk about holistic and person-centered care, and very much in line with palliative care and, like I said, social work as well. Just in terms of when we mentioned identity, I'm sorry, I'm having trouble. Next slide. Okay, so just to focus a little bit about identity, and what do we mean by identity? Well, I wrote life interrupted. It's life interrupted and life disrupted, right? I'm going to focus a little bit now on caregivers, and that's a little bit more of my area of focus, I would say. And so I'd like to bring in the elements when we talk about identity of the caregivers and how their identity can be lost in their caregiving trajectory, depending on, again, the length of caregiving, the length of the illness. There could be a disruption or an interruption of someone's identity. They may become very much in tune with their caregiving identity and allow and just by time and so on, a lot of their other identities fall to the wayside. So we are constantly defining and redefining ourselves, child, parent, partner, nurse, social worker, etc. When you become a caregiver and the caregiving role takes on more and more of your time, you tend to, or you can identify more and more with that identity, leaving the others to the side. And the reason I mention that is because of the grief and bereavement that could come along with the sense of one's identity. It could have a definite impact, a negative effect on how we respond in our bereavement as well. We need to transition out of caregiving, and that is what a colleague of mine who wrote an article on that, talking about post-caregiving and post-caregiving bereavement. And there have been some studies that show that caregivers, just being a caregiver is in fact a risk factor as well for complicated grief. So I think identity is a very important concept in end-of-life care and in palliative care as well. If we go on and we talk about some of the interventions that could help explore and help people with the concept of their identity as a caregiver, and also, of course, the identity of the person who is ill as well. If the identity of that person becomes only the sick person, if that's all that their family allows for them in their living of their illness, or that they allow for themselves, you could see how that could have a major impact on how they live that illness if their identity is only as a person who has an illness. They are reduced in their identity, and that could have a very negative impact on how they live their end of life. So some of the interventions, some of you may have heard of Harvey Chosnoff's dignity therapy, and if you haven't, please Google it. It's a wonderful approach, and it really looks to restore and maintain a person's dignity throughout their illness trajectory. We talk about life stories and allowing people to talk about who they are and incorporating that into their care. Pre-death support to caregivers is extremely important as well in identity post-care and post-death. So if we see that they're not having enough time to continue to, have an afternoon off to continue an activity that they've always enjoyed doing, and it brings them a lot of self-worth, we may be looking at helping them access let's say respite care, so that they can continue to participate in something that brings them their self-worth and enhances their identity in other areas of their life. Music and art therapy, recreational therapy, and volunteer supports and accompaniment. How we know that that volunteers and the discussions and conversations that they can have with someone who is ill can bring so much to that person and enhance other areas of their life, giving them the opportunity to talk about the music that they enjoy, to talk about their career that they had, to talk about the other aspects of their identity that are extremely important to them. I really like this quote because it sort of brings in the whole aspect of what Marnie was talking about as well. You can clutch the past so tightly to your chest that it leaves your arms too full to embrace the present. And that has a lot to do with identity and about how illness and the amount of space that an illness is allowed to take on in a family's life. And it also has to do with grief. If people are holding on so much to the past and the relationships and that they had with the person that died, they don't allow themselves to grieve the present and to incorporate that grief and that loss into their present life and into the future. Talk about strengths-based, and Marnie brought that up as well, and I think it's really important because we talk a lot about strengths-based as an approach that was developed in social work, and it is an approach that I particularly like to use when I'm working with people that are dying, and that is it really brings in, again, some of the concepts and dimensions that we've been talking about. It's to value everyone's lived experience, and lived experience right until the very last breath of life. If they enjoy comedies and watching great comedy and movies, then why not enjoy that right until the very last breath, and not only be the person who's holding that illness, but that they can continue to value and experience life as normal as they can. That people are active participants in the helping process, and that's the empowerment part of the strength-based approach, and that people have strengths, and that we need to focus on that, and that they are resilient, some more than others, again, really very person-focused, and looking at how they've coped in the past, what are some of the strengths that they have, and how they can continue to use that or adapt those strengths to the position and the situation that they're in. And that strengths are also internal to the person, but also in their environment. So what are the strengths of that family? What are the strengths of those caregivers? And how can we incorporate those strengths into a better quality of life? So some of the interventions that are strengths-based are when we look at providing whole person assessments. We're including not only the person with the illness in that assessment, but as well as their caregivers. And we're including them as partners in that assessment and not as objects of that assessment. And that's strength-based. Contribute pertinent information at rounds in our teams. Making sure that the strengths of that family and that person are brought to team discussions and to rounds, that we're bringing forth that experience, that we're bringing that person live to that meeting if they're not able to be there. We can be very, efficient in facilitating patient and family conferences. We could facilitate and mobilize people in these conferences, and making sure that, again, that we're looking at the whole person, that we're discussing a whole person care, and that it's centered on what is preoccupying or worrying that family and that person with the illness, and that we're addressing those issues. Assist with advanced care planning also is a strengths-based. We're bringing out communication and the options and decisions and ideas of what that person wants for end-of-life care. So we think that's very important as well. And also support for life review and goal setting. Again, doing that in partnership with the person with the illness and their caregivers is also another approach. Another principle is the interdisciplinary team, which Marnie mentioned as well, and sometimes our role is to support the team and to help them with the emotional care, as we call it. Bringing in the whole person and the psychosocial perspective to the team. Who is this person with this illness? They are not just Mrs. So-and-so with advanced lung cancer, but they're actually, Jill, who is a mother of 2 young children with this partner and a career in hand, that we bring all of that person to that meeting, and we advocate for that. We also help express the voice of the individual, like I said, and bringing forth their needs in other areas, and making sure that the team is looking at the whole person in their approach. Some of the interventions, so we have, we can model and teach self-care and boundary setting, setting limits, setting not only limits, but also putting out there what our capacities are, again, strength-based, helping teams to build resilience through meaning-making and rituals. Post-death rituals are extremely important for the team as well. Having memorial services as well can help also build resilience and helping the team in terms of their ending termination with that person and their family. We can provide grief support to staff. Sometimes there are certain people that we're caring for that touch a certain member of our team in a greater way than perhaps someone else, and might bring something to them that we may need to sit down with them and help them express that. Also, providing grief support to staff, I said that, but also critical incident debriefing, which Eugene Dufour talks quite a bit about if you have a chance to see any of his work. But again, getting the team together, the importance of being able to end our relationship with one person that we're caring for in order for us to assume other caring, relationships is extremely important as well for our resilience as a team and also for our resilience as individuals. Caregivers need to be included, and I think palliative care, if there's any approach that tries to include them, it's palliative care because it's written right into our philosophy that families and caregivers are important partners in care. And I think that we still have a lot of work to do in that area, as we could see from this quote. I thought it was very pertinent to bring it in at this point. I'll just read it very quickly. My spouse wanted to stay home during his final illness, and I did my best to respect that wish, but it put a lot of stress on me. Because of the person with the illness is the focus, caregivers can feel isolated and burnt out. I felt like I was the only one going through it. And I think in this particular situation, we could certainly read into the fact that this caregiver was not being treated as a partner, and it was not being part of the care that is needed for, in these situations. So I think it's really important that we don't forget about caregivers, that they're very significant, and they have 7 domains of needs. They have caregiver needs and personal needs, and sometimes they overlap and sometimes they don't. So they have a need for information, all kinds of information, how to care for someone at home, how to access services. Those are 2 big areas of information needs that caregivers have that would, cause them a lot of stress if they don't have that information. You can imagine that if you're given the task to monitor someone's medication intake and you've never done that before in your life, how difficult that could be if you're looking and trying to monitor symptoms, and it can put a lot of stress on individuals. Physical, they have needs for their own physical being, how to transfer people properly, how to turn someone in bed properly so that they don't put their own physical health at risk. They also have the need to not neglect their own physical health, which some of them do tend to do. And so we need to remember that they have personal needs as well, and that they have their own doctor's appointments to take care of, and so on and so forth. Psychological and their spiritual health, they have also needs in those areas. Financial and practical needs, if they have to, figure out what it is and how they can get some financial support. They also have a need for practical issues, how to access Meals on Wheels programs, for instance, or how to access subsidized equipment supplies, how to make sure that they have someone there at the right times during the day to help them, to relieve them of certain tasks, how to organize a care plan. These are all things that don't come naturally to a lot of people, and so we have to make sure that they are equipped and that we're there to guide them and journey alongside them and give them the proper supports that they need to make their caregiving a little bit easier. They have caregiver-specific needs, and that could be what I talked about earlier in terms of tensions. They may have some very difficult, distressing symptoms of their own when it comes to taking care of someone that is significant to them. And they may have a lot of stress on them in terms of dealing with other family members. There might be some tensions and some boundaries issues that might be going on. So we need to look at those as well. Those are part of their needs. And then, of course, the bereavement needs that we've already discussed. They also have not only their own grief issues, but maybe they're also supporting other family members through their grief as well, and how do they manage all of that. So it's important to keep those in mind when we're trying to work and help support caregivers. I'll pass it on to Marnie at this point. Thank you very much.
So I'm going to take us through the last few slides fairly quickly so that there's time and space for some questions and maybe some discussion. But Zelda and I decided that we would put up this dual process model slide because I think, you know, although Strobe and Shute created this around bereavement and people's grief experience after a death, I think it's a very useful lens for us to have really as we're supporting anyone with a significant life experience, whether it's an illness, whether it's an end of life or life-limiting illness or anything. This is a really helpful model, I think, as we as professionals are assessing how people are doing. And so very quickly, this model, what Strobe and Shute say is that what you're looking for in terms of healthy or adaptive grief is, does this person in front of you have the ability to kind of oscillate as needed back and forth between what they identify as loss orientation and restoration orientation. And over the years, I've translated those for me to be loss and life. So is this a person who is able to lean into the experience and the meaning and the significance of the loss, and also be able to lean out and engage with activities of daily life? Are they seeing people? Are they getting up out of bed? Are they still eating? Are they finding activities that still feel worthwhile or meaningful? So really what you're looking for in people is that ability to kind of move back and forth as needed between kind of the significant stressor and other activities, and how is that movement going back and forth. So when you think of a person, a patient or a family before death, you know, is the illness taking up all the space, or is there any room for the other parts of who that person is, as we talked about with this psychosocial lens, those key principles? You know, where is identity? What are the strengths? How are those other pieces kind of brought into play in terms of this person's daily life? And we're not at all looking for it to be 50-50. You know, people don't need to be 50% of their energy spent in taking in the illness and what it means, and 50% in kind of leaning out of it and the other activities. But really the sign of health is that ability to kind of move back and forth as needed. So just wanted to put that model out there as a useful lens, I think, as we're looking at people facing illness and significant stressors. This next slide is just some things going on that we wanted to make you all aware of, that if you're particularly interested in palliative or end-of-life care, that you might want to explore further. So the CHPCA has a social workers and counselors interest group through the CHPCA. So if your organization is a member of this, or you as an individual are a member, you can join this interest group. There also is, related to this, a Facebook page that Zelda and I try our best to kind of keep content going, and other professionals around Canada are sharing resources and tools and things that they're working on. So that's something to look at. This framework on palliative care in Canada was the outcome of a national kind of survey that was done around access to palliative care and what Canadians were saying they need. And there's some fantastic information out there. For me as a 30-year palliative care person, shocking to hear the real gaps and struggles in access to care. So that's a good resource to look at. A number of years ago, some social workers across Canada came up with core competencies for palliative care, and that's this scope infographic there, social work competencies in palliative care. And that document is available through the CHPCA website and has curriculum that schools of social work can use to access different parts of it for teaching. And then the last thing is kind of in the thick of the COVID-19 pandemic in the early days, a number of us who are connected with Canadian Virtual Hospice put forward the idea of a Canadian Grief Alliance that was in some ways stimulated by the COVID-19 pandemic, but really, you know, if we're honest, is a kind of long-standing need for raising awareness and building grief literacy in Canada. So the Canadian Grief Alliance is a place that's kind of situated within Canadian Virtual Hospice that I point any and all of you to kind of lend your support and your name to. Joining really is just a show of support. There's no expectation or kind of commitment to it, but really saying, joining with Canadians and professionals across Canada to say we need more access to good grief information and supports within programs. In conclusion, so education about death, dying, and bereavement is important for providers and the general public. That person-centered care requires a multidisciplinary approach that engages the person, their family, the community, and diverse healthcare teams. And bereaved people benefit from learning they're not alone, that grief isn't bad, and also understanding that it's a lifelong process. We wanted to share some resources with you that are useful for people going through an illness and experience, but also for professionals. Canadian Virtual Hospice has all kinds of really good information, from their mygrief.ca website to kidsgrief.ca. There are Indigenous Voices modules for learning. I think really important for us as healthcare providers to know that through the Canadian Virtual Hospice website, there is an Ask a Professional feature where anyone from the general public, and we know that people actually from all over the world, can write a question in and have a response from a professional healthcare provider. So there are physicians, counselors, spiritual health people, and nurses that all respond to those questions that come from the public at large. So anybody who has a question and is having trouble accessing care or resources could use that Ask a Professional option. The CHPCA does all kinds of webinars and conferences and things like that for people to be aware of. The Social Work Interest Group through Facebook, as I mentioned already. SWPN is the American Social Work Hospice Palliative Care Network, and they're very sophisticated and have lots of fantastic content, so that's something I think to have a look at. Many of the provinces have provincial level palliative care associations or hospice associations that we can join. There are illness-specific support groups for the public to know about and for us as professionals. Zelda has put in here a link to the Caregiver Compass, and also that a number of provinces in Canada have developed social work core competencies. So Quebec, Ontario, Nova Scotia, and BC all have worked on developing some social work competencies that we can look at within our provinces. And then last thing, an opportunity for you to think about, what is a challenge that you encounter in providing psychosocial care with people who are dying at the time of death or into people's bereavement? That could be something to just take away and think about, or part of our discussion. And then the last slide is opening up to questions. And if any of you have questions that you want to follow up on or things that we didn't get to, Zelda and I are both long-timers, super invested in psychosocial palliative care, and we would welcome hearing from you if you have questions.
Amazing. Thank you so much, both Zelda and Marnie. What an incredible opportunity for us to have some more conversations around this. We do have some questions, but please type your questions now if you have any. We do have about 10 minutes for a Q&A, so you can use that Q&A bottom widget at the bottom of your slide. There also is a handout widget. So in that handout widget, you're going to have the slides from today's presentation that they have so graciously provided you, so that you'll have those resources as well as their contact information if you want to get in touch with them after today. So please use that Q&A tab. To start, either of you can answer this question. I'm not going to call out one of you specifically, but we do have some, especially some students that are joining on to these live webinars. So I'm wondering if you can provide some students who potentially aren't going to go into palliative care, advanced care planning, or any kind of palliative care. Why is this also important for them to have in their social work toolkit? And do you think that social workers come in contact with grief often, even if they're not in the field specifically?
I could, Marnie,
I'm going to let you take this one, Zelda.
Okay. I have a huge investment in students, and I've been trying to get the scope, as Marnie mentioned earlier, into a curriculum over here where I'm at in Montreal. The reason I think that it's important that students are equipped with this type of training is that grief and loss and adaptation and transitions are part of all of the clientele, all of the populations that we work with. I don't think we can name one area of work, social work practice that we don't come across loss. So, if someone might say, well, I'm working with children, for instance. Well, children come across loss. They lose grandparents, they lose parents, they lose siblings. They lose sometimes their home environment, for instance, if they have to go into a placement, for instance. So, I mean, I think that I would be challenged by anyone listening today to find an area of social work practice where we don't have to come across all of those different areas. So, I think for me, learning to understand grief, loss, bereavement, death and dying, it touches all aspects of social work practice, in my opinion, and I think it's a really important part of our training. And we see that now in practice where social workers don't necessarily always feel comfortable dealing with these issues, and it's possibly because it's not part of their training. And the other part, the question was, so I think it's a very important part of the toolkit. I think that the second part of the question was around content?
Yeah, the reason that this question has kind of come up is it's come up a couple times when we did a webinar on grief. So not necessarily about death and dying specifically. Grief is a bit broader of a concept. But in terms of like direct training, in terms of grief, in terms of death and dying, I think that it's important to have the conversation as to why students might need this kind of training, just like we might get training with individuals and families. So I was just wondering if you could speak a little bit more to potentially certain ways that students can learn more about death and dying and why it's important to them if they aren't necessarily in the field of death and dying specifically, which you have. But
the other part of that as well is that we know that when we looked at the demographics a little bit earlier, we see that there are going to be more and more people dying, and there's going to be more and more individuals who are going to be in the older population. And so there's going to be more and more work in that area as well in terms of social work practice. So even if you're working in a dialysis clinic, say, for instance, in an acute care hospital, you're going to come across people that are older, and you're going to come across people that are dealing with perhaps the issues of death and dying. It can pretty much anywhere where you're working, death and dying is present. We don't necessarily always think about it in that sense. So if you're working in oncology, if you're working in pediatrics, even if you're working with a home care, I've worked in home care for over 30 years, and we are always saying, well, we take care of people at home, and yes, they're in loss of autonomy. Well, people that are in loss of autonomy are dealing with issues of grief and loss. They're dealing with issues of adaptation and transitions. And yes, they're faced with death and dying because a lot of them are older, and older people do think about dying. And so they don't have the opportunity always to have a discussion about how they feel about it or what their wishes are. And I think if we were more comfortable with the issues of death and dying as professionals, we would be able to broach those subjects and allow that communication to happen, and in a sense where we're comfortable with the subject, and the person that we're discussing it with feels our comfort level, and they're able to express themselves. come across many people when I was in frontline services, where I would bring up the subject of, have you thought about where if you wanted to die at home? And sometimes people were like, wow, you're the only person that ever asked me how I felt about dying, or how I felt about the loss of my husband, we were married for 60 years, and yet nobody asked me if I was grieving his loss. Or many times there are, younger caregivers. I say younger caregivers, I mean 50-year-old caregivers taking care of a parent, and the parent might be in their 90s, and nobody asked that caregiver about their grief. You've lost your mother, whether you're 50, 40, 20, or, there are different life course development, of course, in your relationship with the person who's passed on, but you still have a relationship of a mother and a daughter. And sometimes we forget that there is a grief process there that's difficult no matter how old you are. And I think if we're more in tune with death and dying, we may be able to help people with those issues, with those issues that are part of everyday life. I hope I answered the question. I can go on and on, but I don't want to, of course.
No, you absolutely did, and I just want to reiterate a little bit of that, because this is a conversation that we've been having in a couple of our webinars in terms of social workers needing to bridge those gaps into potentially conversations that we have long deemed sticky or uncomfortable. And I think that death and dying, especially in the time of COVID-19, is something that we all need to get a little bit more comfortable with being upfront and honest about. So thank you, Zelda. I appreciate that. I have one kind of overarching question, I guess, for the both of you. As we look at this idea of a just recovery, so this kind of idea of a recovery, not post-COVID, but a recovery from this pandemic, we're looking at a new hopeful future in which everyone is included and we move up and forward. What would you like to see in terms of a just recovery when it comes to psychosocial practice, when it comes to bereavement, when it comes to death and dying? What would be some of your key things you'll be looking for as we transition to a hopeful recovery from COVID-19?
You want to go ahead?
I'm sorry, I was not paying good enough attention because I was responding to a question in the chat. I'm so sorry. So I'm happy to hear the question again, Alexandra, or let Zelda go ahead and answer.
The question is just,
I'm sorry.
Don't be sorry. No. There's a lot going on and we have incredible questions. I'm curious as to what would be some of your big pieces that you're going to be looking for in terms of this idea of a just recovery. So what are you going to look for if the government and civil society and everyone's going to come together and we're going to create hopefully a recovery plan that includes justice and what we're calling a just recovery? What are going to be the key things that you look for in terms of that recovery plan for death, dying, and bereavement?
And you're talking about post-COVID, is that right, Alexandra? Is this about in response to the COVID pandemic?
Yes and no. I think that the COVID pandemic has provided us an opportunity to talk about this more. However, like individuals like you who have been in the field have been, I assume, calling for certain things for a long time to hopefully get some more support. What are some of the big pieces you're hoping to see, hopefully coming out of a potential recovery plan? But what are some of the key things that you think the government should be doing and civil society should be doing to be better at addressing what you had brought up throughout the presentation? If that makes sense.
Yeah, so this is a very much a social work lens, and you introduced me as a social worker, Alexandra, and I'm not. But what I love about social work is that kind of social justice and advocacy lens. I guess what I would say that I can see, and Zelda, you jump in, is I think it's going to take a whole lot of making levels of government, so federal and provincial, and health authorities begin to kind of get over their own death denial and grief denial, and really to understand and probably in a dollars and cents kind of way, the kind of social and health impacts of unattended sorrow, of living with grief that really isn't recognized. And, you know, when I think of your question earlier, one of the things I was going to add is to say, I don't think we as a society do all that well with the hard stuff of life. You know, we don't have a whole lot of resilience and capacity, many of us, and strategies for coping with intense emotion or distress. And we tend, in the face of it, to kind of either tiptoe around it, avoid it, shut it down, pretend it's not there. And I think what building grief literacy as a country will do for us is really develop capacity so that people, you know, very often around a bereaved person, people will say, oh, I didn't ask about her husband who died because I didn't want to upset her. And I think the subtext of that is often, and I don't know what to do with it. You know, if she started to cry, I would feel bad, like it was my fault, and I wouldn't know how to make it better. And so I think a lot of what we need to do is really build a sense of competence and a willingness to step in. And I think it needs to happen at all levels. It needs to happen neighbor to neighbor and friend to friend, and within families and within education, from elementary school up to higher education. And really, I think what social work could do really well is lobby and advocate with government around the importance of that, and really come to the dollars and cents impact of what happens when bereavement is not well supported, when grief is not well supported and understood in terms of significant social and health outcomes.
Yes.
I would add to that. Thank you. That was great. But what I would add as well is I think that as a social worker and as a member of the social work profession, I think we have to find our voice. I think we have a lot of really great skills. We have the training to develop these skills, the skills of advocacy, championing, being a champion for the individuals that we're working with and their caregivers. I think the social work profession, though, needs to find a voice. I think we've gotten lost in the voice. I think part of the problem is, as Marnie mentioned, is that psychosocial issues and psychosocial challenges, the stuff that we deal with day to day, and has, you know, come to light during COVID, is that people are struggling. We know those struggles. We know where the gaps are in how people are able to function, and how to help people problem solve, and how to find their strength. And we ourselves need to do the same thing for our profession. We need to find our voice. We need to bring that voice to the table, and we need to make sure that psychosocial issues and the psychosocial challenges that people face need to be addressed. And that becomes part of advocacy, but we need to not only advocate on a macro level, we need to advocate on a micro level as well. We need to sometimes even advocate within our own organizations to say, well, what about this? And I think that's going to be the challenge as we move forward. We need to step up, and we need to make sure that our voices are heard, but we also have to find our voice. And the better we're trained to deal with the really hard issues of life, like death, dying, and grief, amongst others, the better we are to make sure our voices are heard.
Yeah, I think that that's an excellent point. And I do think that, especially, you know, as we have more individuals start tuning into these continuing online education opportunities, we actually have a really incredible opportunity to provide social workers who may not be in this space specifically with some of these tools. So please, if you are a CSW member, feel free to share this webinar, go through the slides, take it to your places, start to use those resources. If you don't work in this field specifically of palliative care, it doesn't matter. You can still use these resources and take them and start instituting some of these principles and these conversations, not just within your, you know, workplaces or with your clients, but within your communities and maybe yourself as well. Do either of you have any kind of final thoughts before we wrap up?
I'd just like to invite everybody to our Facebook page, the Social Work Interest Group. The better, the more conversations we have amongst ourselves, the more that we help each other in growing and learning about some of the challenges that we face. I think that will make our community of practice a little bit stronger as well. So I invite you all to join the Facebook page if you can. And thank you very much.
Excellent. Okay, well, with all that, I think we will wrap up. If I just see a quick question, if you need the slides from today, they're in the handout section. Please find that widget on the bottom of your screen. It should be blue and look like 2 pages. You'll be able to download the presentation slides from there, as well as access to our peer-to-peer support group. I am going to post the CPHA Facebook or whichever Facebook group on the peer-to-peer support group, so you can access it there as well. Another huge thank you to both of our webinar presenters who have not only taken, over an hour of their day today, but all the preparation and planning to host this webinar. Thank you so much for your time and your expertise. We're so lucky to have you. And with that, we're going to wrap up. Thanks to everyone who attended, and we will see you soon. Okay, goodbye.